Good afternoon. Welcome to week 5. Your lecture this week is going to be Mobility Part 1. So some exemplars are the concept of mobility. We're going to talk about transfers and body mechanics, the concept of good postures, the bad postures, and the correct postures. So just a few definitions. Mobility is the freedom and independence in all purposeful movement. Functional musculoskeletal and nervous systems are essential for mobility to happen. Mobility is included in the biophysical concept category. Immobility is the inability to move freely and independently at will. The risk of complications will increase with the degree of immobility and the length of time immobilized. Periods of immobility or prolonged bed rest can cause major physiological and psychosocial effects. So that is extremely important. And I want you guys to keep that in the back of your mind and remember it in your practice, because especially for older adults, when they don't move, 1 day of being in bed is the equivalent of like 3 days being in bed for them. Sometimes if they're in the hospital for just a couple days, they have to go to short-term rehab to learn how to walk again and to gain strength again, because they get very weak very quickly. Even in regular healthy adults it happens, but it's much, much worse in that older adult population. So always want to think about when you're getting your patients in the hospital, when you're getting a report on them patients and you know that they're not very mobile, that should be one of the things that you think about during the day. Coordinating with your tech, talking to physical therapy, doing what you can to get your patients moving, even if they're just doing some exercising in bed. All right, so the function of the musculoskeletal system in movement. So the framework of bones, the joints between them, the cartilage that protects our organs and allows us to move is called the skeletal system. This is kind of just like a little review from your A&P. Functions of this system include supporting the soft tissues of the body. This helps us to maintain body form and our posture. It protects crucial components of the body, such as our brain, our lungs, our heart, even our spinal cord. Furnishes surfaces for the attachment of muscles, tendons, and ligaments, which in turn pull on the individual bones and help produce that movement that we get. Providing storage areas for minerals such as calcium and fat, and it produces blood cells. Hematopoiesis, taking it way back to anatomy and physiology. Do you guys remember those things? The strength and flexibility of the skeletal system also depends on the patient's ligaments, the tendons, and the cartilage. Ligaments are very tough, fibrous bands of connective tissue. They bind the joints together and they connect bones and cartilage. The tendons are also strong, flexible, inelastic fibrous bands and flattened sheets of connective tissue that attach the muscle to the bones. Cartilage is hard, non-vascular connective tissue found in our joints, as well as we have them in our nose, in our ear, our thorax, our trachea, our larynx. Cartilage in joints function as a shock absorber, and they provide a smooth surface that reduces friction between the moving parts of the joint. Fat may also provide some padding in our joints as well. So there are 206 bones in the human body. They are classified by their shape. Our long bones are usually found in the upper and lower extremities, so your humerus and your femur, they contribute to the height and the length. You have your short bones, which are located in the wrist and the ankle, and they contribute to movement. You have your flat bones, which are relatively thin. You can find these in your ribs and several of the skull bones, and they contribute to the shape and the structural contour. And you have your irregular bones, which are all those bones not included in the preceding classification. So your bones of the spinal cord and maybe the bones in your jaw. So joint movements. Again, this is all just kind of like a, reintroducing you to what you had when you were in anatomy and physiology. So you have your adduction, which is the lateral movement of a body part toward the midline of the body. So for an example would be a person's arm is adducted when it is moved from an outreached position to a position alongside the body. You have circumduction, which is turning in a circular motion. It combines abduction, adduction, extension, and flexion. An example of circumduction would be circling the arm at the shoulder, as in bowling, or maybe you were doing a serve in tennis. Flexion is the state of being bent. For an example, a person's cervical spine is flexed when the head is bent forward, chin to the chest. We have extension, which is the state of being in a straight line. An example of extension is a person's cervical spine is extended when the head is held straight on the spinal column. We have hyperextension, which is the state of exaggerated extension. This often comes in an angle greater than 180 degrees, and an example of that would be if a person's cervical spine is hyperextended when looking overhead, like towards the ceiling. We have dorsiflexion, which is backwards bending of the hand or the foot. An example would be a person's foot is in dorsiflexion when the toes are brought up as though to point them at the knee. Plantar flexion, which is flexion of the foot. An example of this would be a person's foot is in plantar flexion, like in a foot drop position, so pointed down. We have rotation, which is turning on an axis, the turning of a body part on the axis provided by its joint. A thumb is rotated when it is moved to make a circle, so that's an example of that rotation. Internal rotation is when a body part turning on its axis towards the midline of the body. So for example, a leg is rotated internally when it turns inward at the hip and the toes point towards the midline of the body. Then we have external rotation, which is a body part turning on its axis away from the midline of the body. For example, a leg is rotated externally when it turns outward at the hip and the toes point away from the midline of the body. So just a little review. So the types of joints, there are several types of freely movable joints that are in our bodies. They include the ball and socket, which is the rounded head of the bone that fits into a cup-like cavity. In the other, there's flexion, extension, abduction, adduction, and rotation can occur, like in your shoulder or your hip joints. Then you have the condyloid joint. The oval head of one bone fits into a shallow cavity of another bone. It allows flexion and extension, and also abduction and adduction, like your wrist joint and the joints connecting your fingers to your palm. Then you have the gliding joint, which is flat surfaces on the bone that slide over one another, also allowing flexion, extension, and abduction, adduction, like your carpal tunnel bones of your wrist and tarsal bones of the feet. You have a hinge joint, which is a spool-like rounded surface of one bone that fits into a concave surface of another bone. Only flexion and extension can occur, so that would be your elbow, your knee, and your ankle joints. You have your pivot joint, which is a ring-like structure that turns on a pivot. Movement is limited to rotation. Joints between the atlas and the axis of the neck and between the proximal ends of the radius and the ulna at the wrist. And then you have a saddle joint, which are bone surfaces that are convex on one side and concave on the other. Movements include flexion and extension, adduction and abduction, circumduction, and opposition. And an example would be the joint between the trapezium and the metacarpal of the thumb. So we have three types of muscle. The muscular system is composed of your skeletal muscle, your cardiac muscle, and your smooth or your visceral muscles. Muscle tissues produce movement by contractions of its cells. Skeletal muscle works with your tendons and your bones to help move the body. Your cardiac muscle forms the bulk of the heart and promotes the contractions that help create that heartbeat. And then smooth muscle forms the wall of the hollow organs, such as in your stomach and your intestines, and is in the walls of blood vessels and other hollow tubes, such as ureters, and may help connect internal organs. So again, this is all just a review for you guys from that anatomy and physiology. So important functions of muscle. So movement is going to result from a skeletal muscle contracting and then exerting that force on a tendon, which in turn helps to pull on a bone. The excitability, contractibility, extensibility, and elasticity of the muscles enable them to perform 4 important functions for the body through contraction. So you have motion. So your skeletal muscle contractions pull on your tendons and they move the bones, create movements such as easy as extending the arm to as highly coordinated as swimming or even skiing. You have maintenance of posture. Skeletal muscle contractions hold the body in a stationary position and keep you upright and strong. Support, it offers support. Skeletal muscles support all the soft tissues in the abdominal wall and the floor of the pelvic cavity. And then you have heat protection. So skeletal muscle contracts and produces heat and helps maintain body temperature. Anatomy and physiology. Your muscles again, you got the skeletal, the smooth, and the cardiac. You have joints, which are the junction between 2 or more bones. Free moving or dithyroidal joints, also called synovial. You have tendons, which are cord-like structures that attach muscles to the bone. You have attachments of muscle. You have ligaments, which are tough fibrous bands of connective tissue that bind joints together and connect your bones and your cartilage. You have your ligaments, which are fibrous tissue connecting the 2 adjacent freely movable bones. You have cartilage, which is firm, dense, a very firm, dense type of connective tissue. You can have hyaline cartilage or articular, costile, semilunar, fibrous, and elastic. These can be found in the nose, the ear, the thorax, the trachea, and the larynx. And they also act as shock absorbers. And then you have the bursa, which are small sacs filled with synovial fluid. And these help reduce the friction between these areas. So the skeletal system provides attachments for muscles and ligaments, and it provides leverage for movement. Skeletal muscles help movement of those bones and joints. And the nervous system is just as important because it regulates movement and posture. So the skeletal and muscular systems cannot produce that purposeful movement that we see without a functioning nervous system. Nerve impulses stimulate those muscles to contract. So the effect of the nervous system on our muscle contractions. So we have the afferent nervous system. So nerve cells, let's back up a little bit. Nerve cells called neurons conduct these impulses that happen in one part of the body to another, okay? So the afferent neurons, they convey the information from receptors in the periphery of the body to that central nervous system. So light pressure on the nose, like in the CNS, that's an example. The information is then processed by the CNS, leading to a response. So there's a fly on my nose, I want to brush it off. Okay, you feel that light pressure on your nose, and then it's processed by the CNS. You feel it and you want to, shoo it and brush it off. The efferent neurons convey the response from the CNS to the skeletal muscles by a way of the somatic nervous system. So the muscles in the arm, wrist, and hand contract, and then the fingers actually can come up and brush the fly off the nose. So you need that afferent nervous system and your efferent nervous system to work in conjunction. Damage to the central nervous system will affect your body alignment, your balance, and your mobility. Problems can come from head trauma, motor vehicle accidents, strokes, meningitis. There are various factors that influence movement and alignment. So a person's age and the degree of neuromuscular development markedly will influence body proportions, their posture, their body mass, any movements and reflexes that they have. So to promote neuromuscular development in patients of all ages and to facilitate each patient's use of body to perform self-care activities, we as nurses have to be familiar with all the developmental variations in body proportions and neuromuscular development. So I don't want you to know all of them right now. We're just going to do a little overview of them right now as we get into other classes, like PEDS and stuff like that. You'll go into detail and really learn a lot of the differences, but we need to understand that there are developmental considerations, okay, that influence the body movement. There are some variations presented in your book with table 33.3 if you want to take a look at that. So some considerations for infants, toddlers, and preschoolers. The newborn's infant spine is flexed and lacks the curve of the adult. The toddler's posture is awkward because of the slight sway back and the protruding abdomen that they have. So I'm sure you've noticed that with some toddlers, the way their little bellies come out, they have cute little bellies. And then their posture is awkward because they go back a little bit because of that little protruding belly. Then you have adolescents. They have imbalanced growth spurt, possibly altered with immobility. They have growth frequently is uneven. So sometimes I've seen it with girls, I've seen it with boys. One breast may grow bigger than the other. You have delayed development of independence and then social isolation. So adults, there are lifespan developmental changes in the adults as well. So for adults, there's alterations in every physiological system. There's alterations in family and social systems, and then alterations in job identity and their self-esteem. For the older adults, they have alterations in balance, which result in major risk factors for falling and having injuries. They have a steady loss of bone mass, which results in weakened bones. So that goes hand in hand with those fall risks. They have a decreased coordination, slower walk with smaller steps. They have alterations in their functional status and an increased dependence on staff and family. So you could see all the things that we just named about the older adult, how they would be at risk for having a fall. So for one, their balance is off. That in itself makes them at risk for having a fall. But then on top of that, they already have weakened bones. So what do we think they're at risk for happening when they have a fall? You got it. They're going to break some type of a bone, which will lead to more issues for the patient. They do walk slower. They have those smaller steps. So our older adults are at a great risk of having a fall due to all these combined issues together. So physical health, a negative influence on body alignment and movement can cause a problem. It can affect your activities of your daily living. So when we say activities of daily living, we mean being able to shower, bathe, go to the bathroom, do your hair, brush your teeth, get dressed. There can be problems with muscle development, which may be genetic. So you could have muscular dystrophies and myasthenia gravis. You could have inflammation and degeneration like arthritis, which is characterized by inflammation, pain, and damage to your joint cartilage and or stiffness. That affects our mobility. You could have scoliosis, which is a lateral curve of the spine. We'll talk about more about that with PEDS. Club foot, which is a congenital deformity of the foot, usually marked by a curled shape or a twisted position of the ankle, heels, and toes. You have foot drop, which is when the foot becomes paralyzed or weak. When paralyzed, the dorsiflex muscles become weak or they can become paralyzed, and those muscles are found in the foot and the ankle. And then you have hip dysplasia, which is congenital or an acquired deformation and a misalignment of the patient's hip joint. So these are a couple of the things that we talked about. You have your club foot right here, some drop foot. This is a Charcot's foot right here. You have this sore and this ulcer that comes because of this fracture. Over here, we have scoliosis. You'll learn about some of these, excuse me, when you do PEDS. We'll talk about all three of these. And then you can see here, excuse me, is a hip fracture. So, injury and trauma, we know, can lead to alterations in functioning, such as a direct trauma to the musculoskeletal area, which could cause a bruise, it could cause a contusion, a sprain, and even a fracture. I'm sorry. So your first bone here is normal. There's nothing wrong with it. The second picture you see is a transverse break. It was right down the middle across the side there, very straight. You have oblique, which is that's another break or a fracture that's on an angle. Then you have a spiral. You have a comminuted fracture, which is a whole bunch of little pieces that broke off inside the bone. Then you have an avulsion, you have an impacted fracture, a fissure, and then a green stick fracture. So those are the different types of injuries and traumas that can happen to bones. So what are the factors that influence movement and alignment? So our mental health plays a big part. Our body process tends to slow down with depression or lack of visible energy. Our body position with depression they would have their head would be bowed and their shoulders would be slumped. I'm sure that we've all seen someone suffering from depression. We know what that body posture looks like. Our lifestyle, so active versus sedentary lifestyle, we know what our movement would be in someone who's very active versus someone who's sedentary. Then we have a person's diet. That's going to also have a play in your movement, and then your smoking history. So maybe if you smoke cigarettes, you're not really going to be able to be as active as somebody else because maybe you have a terrible cough or you get out of breath very easily, or if your diet's not great, maybe you're overweight and you don't want to exercise because it's not comfortable to exercise. So your attitudes and values also influence your movement. So it may be internal. So regular exercise, in some families, they are raised to do a lot of activity, physical activity. So in families who like to hike, swim, or play ball together, these children learn very early the value of incorporating regular exercise into your life. As these children mature, they often continue to value exercise and find new ways to incorporate regular exercise into their daily routine because that's how they were raised. On the other hand, some children may be raised in families who are very sedentary and they watch sports, and just watching sports is the closest to any activity they ever come to, so they're very sedentary. Attitudes and values learned early may be internalized for a lifetime. It might be really hard to get out of those rituals that you're so accustomed to because you've been doing them your whole life. And then we know fatigue and stress is going to influence our movement. So chronic stress can deplete body energy and make you not have energy to do anything. And then external factors such as weather, sufficient financial resources, a lack of free time, they also affect the amount of activity that we get in and our mobility. An exertion, active exertion of muscles involving the contraction and relaxation of muscle groups is exercise. And I think we're all pretty familiar with exercise, some more than others. We know what it means and what it involves. So exercise, the activity of exerting your muscles in various ways to keep fit, which enhances the patient's physical condition and improves their health. We know this statement is 100% true. There have been study after study after study. We all need exercise. Our heart is a muscle. It needs exercise. We all need to be incorporating exercise into our life on a weekly basis, several times a week. Individuals who exercise regularly have improved activity tolerance and decreased fatigue. It's good for everything. So exercise, two major types. Exercise can be categorized usually according to the type of muscle contraction that's involved, being isotonic, isometric, or isokinetic. So isotonic is muscle shortening and active movement. So you would see isotonic contraction in swimming, walking, and jogging. And you have isometric, which is muscle contraction without shortening. So holding a yoga pose is a good example of an isometric contraction. And then you have isokinetic muscle contraction with resistance. So that would be lifting weights. Then you have body movement, which includes aerobic exercise, stretching exercise, strength and endurance exercise, and movement and ADLs. So what effects do exercise have on the major body systems? So our cardiovascular system, what does it do for our heart? It increases the efficiency of our heartbeat, okay? It decreases our heart rate and our blood pressure. Why do you think it decreases? It decreases because it works more efficiently. So it doesn't have to work as fast or as hard because it works more efficiently. It increases blood flow to all of our body parts. We have improved venous return, which means that blood that's being pumped out of the left side of our heart and going through our body is coming back up to the right side of our heart for reoxygenation. We're getting a great venous return. And then we have increased circulating fibrinogen, which is a substance that breaks up small clots. So you're not going to develop blood clots. What effects does it have on our respiratory system? Well, it improved alveolar ventilation. So you remember back to anatomy and physiology, all those little alveoli that are inside of your lungs that, you know, the more air you take in, the wider they stay open, the more air that comes in, so you get more ventilation. You have a decreased work of breathing. You don't have to work as hard because your respiratory system has improved ventilation, so it can work easier and more efficient. And then you have improved diaphragmatic excursion. So it works on more body parts than just your cardiovascular and your respiratory system. We have good effects on our gastrointestinal system, so it helps our appetite increase. Our intentional tone is increased, which improves digestion and elimination. And then weight can also be controlled through your exercise and how much you eat. Your urinary system is improved. You'll have improved blood flow to the kidneys. It's going to help your skin, so it's going to promote overall general health of your skin. And it also improves your psychosocial outlook. So it gives you increased energy, vitality, and just a general feeling of well-being. It improves your sleep at night. It improves your appearance and your body image. It gives you an improved self-concept of the way you see yourself and feel about yourself, and it causes an increased positive health behaviors. So exercise does a lot. What does it do for the musculoskeletal system? It increases muscle efficiency, so you gain strength and flexibility. It increases your coordination. It reduces bone loss. So remember back to the older adults that we talked about. So incorporating exercise into their daily regimen regularly would be really good for them, right? Because they suffer from an decreased coordination. They suffer from bone loss, okay? They're not as strength and as flexible as they used to be. So this is a good example of how we can promote that exercise in your adult years and carrying over into when you become an older adult. You see how important it is. You also have increased efficiency of nerve impulse transmission, and it helps prevent osteoporosis, the process of our bones demineralizing. It also has positive effects on the metabolic process. It increased triglyceride breakdown, which are those bad fats. We have increased gastric motility, and then increased production of body heat. A lot of good things that exercise does. So it affects interventions of immobility on the body. It's going to affect all of the same systems. So lack of exercise, inactivity, being immobile related to an injury or an illness places a person at high risk for serious health problems with potential complications across every body system. So immobility can affect the major body systems, and it's been linked to a predisposition to many chronic health problems. The benefits a person receives from exercise, the complications resulting from immobility differ in their occurrence and severity based upon the patient's age and overall health status. So you can see how much good you gained from exercising, and then you're also going to see how much bad can happen when you have a lack of exercise. So again, it's going to affect the cardiovascular system, the respiratory system, the musculoskeletal, those metabolic processes, your gastrointestinal system, your urinary system, your skin, and then your psychosocial outlook. And here's just a little chart that shows you the effects of immobility, such as muscle atrophy, You're going to have nutritional intake due to anorexia and restrictions. You're going to have increased weakness, further loss of muscle mass. It's going to eventually cause a negative nitrogen balance. So the effects that you see from immobility on the body for your cardiovascular system are your cardiac workload is going to increase, which means that the heart is going to have to work much harder than it normally did to get out the same amount of blood circulating in the body to properly perfuse all of those organs. You can see orthostatic hypotension, which is orthostatic hypotension is when you measure a patient's blood pressure. You guys will learn more about this in 3 different positions in 3 minutes apart. You have them lay down and you measure it, then you have them sit up and measure it, and then you have them stand up and measure it. And if they have a decrease in their systolic number, more than 20 between those changes, those 3 position changes, or diastolic more than 10 or more, then that means they have orthostatic hypotension. You're going to have venous stasis, which means that heart is trying to work so much harder to get all that blood out, okay? So you're not getting that good venous return. So if you're not getting that good venous return, the blood comes out the left side of the heart, it goes through the body, and then maybe when it gets to your legs, it's going to pull, it's going to stay. And that's going to cause venous thrombosis, or what we call blood clots. So what are some interventions you can do to help that immobile person? You can mobilize the patient as soon as possible, even to sit on the side of the bed. Something just as simple as sitting to the side and dangling those feet. Get the patient slowly out of bed, allowing them to rest and dangle their legs in a sitting position and move slowly when standing. You're going to measure that orthostatic blood pressure and pulse. We just talked about that, lying to sitting to standing, and assess for dizziness. So that is a sign of orthostatic hypotension when they change those positions and they get dizzy. So if that happens to your patient, you want to slowly just get them to the edge of the bed, support them. Don't encourage them to stand until the dizziness has resolved. You want to discourage the patient from using the Valsalva maneuver when defecating or moving up in the bed. So that feeling that you have when you're trying to have a bowel movement, that pushing down, that can cause the patient to pass out. We call that the Valsalva maneuver. Give a stool softener to your patients to prevent them from straining. You want to instruct your clients to perform isometric exercises to increase that activity tolerance. You want to teach range of motion and in the bed. They can do it in the chair, they can do it in the bed, they can do it with physical therapy, and you want to give them anti-embolic exercises. They can do ankle pumps, foot circles, and knee flexion to keep that blood from pooling in those lower extremities so you don't get a clot. And then you want to change positions as often as possible. So, avoiding them blood clots, we can place our patient in anti-embolic stockings. So these are used for patients who are on bed rest. We give it to patients that are pregnant, after they've had surgery, or with any kind of circulatory disease. Before we apply them, we're going to assess the skin, look at their circulation and the presence of any edema in the legs. We're going to measure their calf and their thigh circumference and the length of the leg to select the correct stocking. So they have thigh highs, which come up to the thigh. We all know where the thigh is. And then they have knee high, and you can see the difference. The knee highs just come to the knee. You're going to turn the stockings inside to the heel. So if you look at the, you'll see these when you guys go to clinical, but if you look at where the toe area is, it's actually open right there. It's not closed like the heel is. There's an opening there. So you're going to turn the stockings inside to the heel. You're going to put the stocking on the foot, and then you're going to pull the remainder of the stocking over the heel and up the leg. You'll smooth away any creases, make sure that it's nice and smooth, and then you can remove them and reapply them 2 times a day. Sometimes the doctors will put in specific orders how they want them. Sometimes they don't, so it's up to your discretion. And then you want to keep the stockings clean and dry, and if they do get dirty for any reason, you can always just grab another pair. So what effects does immobility have on the respiratory system? Well, it decreases your ventilatory effort, decrease in the depth and the rate of respiration and possible causes atelectasis. So that's the incomplete expansion or the collapse of that lung tissue, all those little atelecti in there. Remember I told you when we give them their incentive spirometer to use, it helps them to breathe in and keeps them all open so that they can get lots of air in there and not any purulent, yucky, soggy wetness inside of there that can lead to infection. And then it causes an increase in respiratory secretions, leading to respiratory congestion and respiratory tract infections. So when atelectasis happens, they close up all those little flower things that the atelectasis occurs, and they get moist and they get wet, and it's a dark environment, it's a dry environment, and that's when you have that respiratory congestion develops, and then you can get a respiratory tract infection or even pneumonia. So interventions that you can give to your patient to prevent that is cough and deep breathe every 1 to 2 hours, and use that incentive spirometer. They can have chest physiotherapy. PT usually comes in and does that. You as the nurse can osculate the lungs to determine the effectiveness of that therapy that they're getting or other respiratory therapy. You can elevate their head of the bed when applicable. You can instruct them on doing deep breathing exercises. You can encourage activity such as shifting or exercising their upper body in bed, and then help keep them well hydrated. As patients really need to have about 2,000 or 3,000 mLs of fluids per day, unless they're on a fluid restriction. So the effects of immobility on the body, your musculoskeletal system, there's going to be immobility, which leads to decreased muscle size. So you're going to have atrophy in your tone, and your strength is going to decrease. You're going to have decreased joint mobility and flexibility. You're going to have bone demineralization, which is also osteoporosis, which is going to result in pathological fractures related to bone brittleness and sponginess. So what are some interventions you can do? You can encourage patients to participate in active range of motion and passive range of motion while they're bathing, while they're eating, while they're dressing and they're grooming. You can get a continuous passive motion device. I've never actually seen that in the hospital, but I have heard of them before. You can determine a progressive exercise program to increase the patient's physical abilities, and physical therapy will come, or occupational therapy will come and help decide that with you. They'll work with them and design a plan for them. You can have, make sure their body is properly aligned, make sure they're sitting up in bed. You can put the bed in the chair position. You can get them to the chair. You can assist the client with ambulating, use assistive devices such as gait belts, walkers, or canes and crutches as much as needed, but you can get them out of bed. And then just want to reposition and turn them every 2 hours. That's very, very important. You want to prevent those bed sores from forming. Okay, so what is the purpose of range of motion? The purpose of having good range of motion is to improve or maintain our joint function, to prevent contractures, to improve muscle tone and strength, and to increase patient comfort. So range of motion is the normal range of motion for any joint. Flexion is how far it can be bent. Extension is how far you can stretch it out. Types of range of motion are active, so the client is independently moving their joints throughout their full range of motion. They do it on their own. Assistive is just what you would think it is. The nurse can provide minimal support, so you're just assisting. And then passive is the client is completely unable to independently do those moves. And the nurse moves each joint through its range of motion until the client complains of pain or discomfort. The nurse then returns the joint to a neutral position. You will see a lot of physical therapists coming and do this to them, to your patients when they are hospitalized, but you can also do it as well. So this is just a little blurb here to show you about flexion and extension, and then deviation, pronation, and supination, but you guys should know this from anatomy and physiology. This is just a little refresher. So flexion, you just want to consider flexion as narrowing the angle. There's a little picture there to help you realize what we're talking about. You have extension, which is 180 degrees. You have hyperextension, which would be greater than 180 degrees. You have abduction, means to take away from the midline. And then adduction, which means you're going to add to the midline or further. Your rotation, which involves around on an axis. And then your circumduction, which is a combination of all other movements to form a large rotation. So the effects of immobility on the body, when your metabolic system, it decreases your metabolic rate. It causes muscle wasting and a negative nitrogen balance. Anorexia and a decreased appetite can happen as a result. Interventions that you can do are to provide a high caloric diet, a high protein diet with vitamin B and C supplements. You can monitor and evaluate your oral intake. For clients who cannot eat or drink, you can provide enteral or parental nutritional therapy. And then your goal is to repair damaged, injured tissues and rebuild depleted stores. So our diet has a huge effect on how we recover from an illness. We need, well, and I'm sure you guys, if you already took nutrition, I'm not sure if you have or not, as a prerequisite to get into this course, or maybe you've taken it somewhere else. We will talk about this further in detail in our nutrition portion, but we really need high caloric, high protein diets for our patients who are sick in order to rebuild and build healthy tissues and have that repair that we want for them, depending on what their illness is. So the effects of immobility on the gastrointestinal system. So it causes their appetite to be decreased, which we said, which they have decreased food intake, which causes an altered protein metabolism. It slows their GI tract down. So if their GI tract slows down, then what do you think it causes? It causes constipation and poor defecation reflexes. So that patient who had the back surgery that's not moving as much, they're not taking in deep breaths, they're at risk for developing pneumonia. Now we know they're at risk for developing constipation, plus we're probably giving them pain medicine, which also causes constipation. So do you see how we're using those critical thinking skills in relationship to that patient that we were talking about? And we're starting to develop all these things that they're at risk for, okay? So what are some interventions we can do? We want to record the frequency and consistency of bowel movements. We want to do strict I's and O's on our patients, which means we want to know everything going in. We want to know everything going out, exactly measured. We want to put like a little, we call it a nurse's hat in the toilet, or a urinal with numbers for the men that have numbers on the side so you can measure their bowel movements and their urine output. You want to have a diet which is rich in fluids, fruits, vegetables, and fiber to help facilitate that peristalsis and maintain regularity for the patient so they can have good bowel movements. You want to maintain hydration, at least 2,000 mLs a day. Sorry, another error. Unless fluid is restrictive. And then you want to give a stool softener or a laxative or an enema as needed. How does it affect the urinary system? Well, the urine remains in, so the patient's laying in bed, they're not really moving. If you imagine that the patient is laying back in a certain position, the urine remains in the renal pelvis for a longer period of time. What happens when that urine lays there? Well, urinary stasis causes the growth of bacteria, which can cause a urinary tract infection. When a patient has an indwelling urinary catheter, it can increase the risk of infection. So you don't want to use them for a long period of time. We have something called the nurse-driven protocol in hospitals where the nurse can assess the need for the patient to continue with that urinary catheter. And if they deem that it's time to remove it, the nurse can remove it without an order. Interventions would be to observe the urine for clarity, color, and presence of any sediment, because a foul odor or a dark color or not a normal color other than yellow or amber, and any kind of clots or any kind of sediment in there could be a sign of infection. You want to observe how frequently they're going to the bathroom. Are they putting out a sufficient amount of urine in your shift? You want to assess for bladder distension to ensure that they're not having reflex incontinence. And then you want to promote urination by, you can pour warm water over the perineal area. Sometimes you can run water. You can put warm wash rags on the abdomen. For men, it's just as simple as standing up and using a urinal. It's very, very hard for men to pee laying in bed. And then even for women, sometimes you just get them up and you can assist them to a bedside commode or the toilet, and they can actually pee like that instead of having to struggle to use the bedpan. It's really hard for people to use, some people anyway, to use a bedpan. So the effects on skin, you can have impaired circulation, which can result in a serious breakdown. You can have, I apologize, prolonged pressure on bony prominences, which produce as an area of breakdown. So like your elbows, your ear, your tailbone, areas like that can cause, can produce skin breakdown. So interventions for the protection of the skin, you want to identify clients at risk for pressure ulcer development. So you know those patients are going to be patients that are not repositioning themselves in bed. Each time you go into the room, if they're in the same position, you know that they're not moving themselves around. Position using corrective devices, so you can roll them on their side and put a pillow under them. Sometimes they have boots. You can do like a trochanter roll, splints and wedges, depending on what your facility has. You can reposition the patients every 2 hours and make sure you're providing skin care. So really looking at that skin, cleaning them up when they go to the bathroom, making sure that their skin is dry and not wet. Teach patients to shift their weight every 15 minutes if they can. Use therapeutic devices to relieve pressure, such as special mattresses and beds for clients in bed for an extended time. Lift patients, never drag across the sheets, and then maintain a clean, dry, and wrinkle-free bed. So this here just shows the areas, depending on the patient's position, that would be bony prominences, that would be major areas where a skin breakdown could occur. So you have the back of the head, you have their scapula, their elbows, their sacrum, their heels. These are the areas that have constant contact with the bed. And if they're not moving from that position, that's where that skin breakdown is going to occur. And if they're laying on their side, they have the malleolus there, which is the ankle bone. You have your medial and lateral condyles. You have that hip there, the greater trochanter. You have the ribs. You have your acromion process, and then, like I said earlier, your ears. And then if they're in the prone position, which I didn't really see a lot of patients in the prone position up until lately through all this COVID, we place a lot of patients in the prone position because it helps their lungs float up towards their back. It takes the pressure off of them and it helps the air get in there. So if patients are struggling with their respiratory drive, we put them in the prone position and it helps their O2 levels come up. But you can see being in that position that your toes are at risk, your knees, your genitals, your breasts, your acromion process again, and then your cheeks and your ear. So these are all good things to keep in mind when you're caring for those patients that really aren't moving. So when a person can no longer move their body purposefully and they need to depend on someone else for assistance with even simple self-care activities, the person's sense of self becomes threatened. Skeletal deformities can influence body image, and inability to meet role expectations can decrease their self-concept. And a prolonged period of lying dependent in a bed can lead to feelings of worthlessness and diminished self-esteem. Patients that can do things for themselves like to do things for themselves. Most patients don't like feeling like they are dependent on somebody else. And for some people, it can be very disheartening. It can make their sense of their self-esteem very, very low. They don't feel good about themselves. They can feel worthless. It just puts them in a dark place. So some interventions that we can do to help with their psychosocial outlook is we can assist them in using coping skills or developing new coping skills. We can get the patient out of the bed. This gives them a sense of accomplishment. It makes them feel like they did something. And even though you're helping them, they're still doing something on their own. You can help to orient the patient to the time. You can have a clock in the room or a calendar. You'll update your board every day with your name and the date. You can talk about where they are, the treatments that they're going to have, what they have done, how long they're going to be here. Call them by their name. Make sure you always introduce yourself. You can provide stimulation and diversions. It's easy to acknowledge someone's feelings, but then you can try to change the subject and talk about something else that would make them happier. You can encourage, well, this is not something that's happening now, but you can encourage family and friends to visit. If they have a cell phone, they can talk to them on the phone. If they can do FaceTime, we do have tablets in our facility that we can set up phone calls with loved ones, because they really need that, especially if they're having a long stay in the hospital and they don't have any visits from their family. That can be a really, really hard thing for patients. And some patients even give up and they don't want to fight because they don't think they're going to get back home, or they don't think they're going to see their family anymore. So encouraging that family and friends to visit or have that phone call or that FaceTime is really, really important. If your patient can get out of bed and walk a little bit with a walker, you can walk them out of their room. You can also put them in a wheelchair and wheel them out. Back before all this COVID craziness started, I was taking care of patients on the oncology floor, and sometimes they had to stay for several days because their treatments ran a long time, and they would be there for 7 or 8 days. And there would be some times where I had a little bit of time in the afternoon and I would put them in their wheelchair and wheel them out front on a nice day. And that just made all the change in their outlook and the way that they saw things, just because they got out of their room a little bit. And then you can also recommend a referral for a consultation. You can have a psychologist come and see them. You can have the chaplain of the hospital come see them. Maybe a social worker can come see them. They're all there to help assist clients that are not coping well with things. So that psychosocial outlook, person's self, oops. I thought I clicked it. I clicked the wrong one, sorry. So the nursing process for activity, you're going to do that assessment, right? You're going to gather a good history on the patient, find out everything that's going on with them. You're going to, excuse me, identify any chronic disorders, medical drugs, past medical history, any current drugs that they take, any allergies, any familial issues that they have, like breast cancers or prostate cancers that run in their direct immediate family, any occupational hazards, or what is their occupation. You're going to talk about their mobility and their exercise. What is their daily activity level? What is their endurance like? How often do they exercise? What do they do for exercise? Do they go to the gym 5 days a week and do weightlifting? Do they just walk around the neighborhood with friends 3 times a week? What are their exercise and fitness goals? Are they doing too much and they want to scale back? Are they not doing enough and they want to push something into play where they're more active during the week? What are their mobility problems that would inhibit them from starting an exercise program? What are their physical or mental health alterations? Are there any external factors affecting them from being mobile at home? The CATS Index of Independence and Activities of Daily Living addresses their bathing, dressing, toileting, transferring, continence, and feeding issues. You can read this on page 1148 of your book if you want to take a look at that. You want to talk about any recent injury, any occurrence of traumas, any complications or problems during the treatment that they've had, and then if they've had any open injuries. So with open injuries, we mean, have they had like a break that caused the bone to come through the skin? Did they have a cut? Did they, cut off a finger, or they have a gash in their arm? Anything that opened the skin, you want to find out when the date of their last tetanus shot was administered. You want to make sure that they are not at risk for developing tetanus, which comes from the rust on dirty nails, and it can be very life-threatening. So then you have your physical assessment. So you're going to assess their general ease of movement and their gait. What does their alignment look like? Their joint structure and their function. What is their muscle mass, their tone, and their strength? What's their endurance? You're going to note whether the patient movement is quick or very slow. You're going to check out their alignment. So does it permit optimal musculoskeletal balance and operation and promote optimal physiologic functioning? Note whether what's their alignment, their balance or posture. Does it refer to the positioning of their joints or their tendons when they're sitting, standing, or lying? When is the body aligned? Where's the patient's center of gravity, and is it stable? Gravity is what we call the weight force exerted by the body. The force of weight is always directed downward, which is why an unbalanced object falls. And in the elderly population, the line of gravity does not pass through the base, which is why they are at risk for falling. So here you can see the center of gravity and the line of gravity. So this is, you can tell how the body alignment is, if it's appropriate or not for your patient. That's just an example. So you want to use inspection and palpation to examine those joints, to check their range of motion and any of the surrounding tissue. Your range of motion is the maximum degree of movement of which a joint is normally capable, okay? So you want to assess their musculoskeletal status. You want to look at their muscle strength, if they have any muscle wasting. You want to look at symmetry, size, their range of motion, their alignment. Do they have any pain or tenderness, any swelling or redness? You want to do a spinal inspection. So you want to check for kyphosis. So kyphosis is the one in the middle there. The shoulders and the upper back actually curve forward. Lordosis is an exaggerated anterior convex curvature of the spine, and then that one is on the end. There's a picture of that. You can see how it goes in. And then scoliosis, which is on the left, is that lateral curvature of the spine. Neuromuscular, you want to assess for any spasms that the patients may have or any tremors. And then you want to make a comparison of the findings in one joint with those of the opposite joint. So if you see something on the right knee, you will want to compare it to the left knee. And if you find something in the right foot, you want to compare it to the left foot. You're always making that comparison between the two when you're doing your assessment. Oops. So more on that physical examination. So traumatic injuries, you are going to assess those vital signs. You're going to look for swelling, any external bleeding, bruising, open wounds, any debris or protrusion of the bone or tissue, like in that nice little picture down there at the bottom. Most of the time, if you're working on a med-surg floor, you're not really going to see this. This is more your emergency room, your trauma centers. You want to assess peripheral circulation, sensation, and malalignment of the injured limb. So if someone has an injury like that, you would want to check their circulation, because maybe they're losing a lot of blood and their circulation isn't well. You want to check sensation to see if there's been any type of nerve damage. And then you want to check for injury beyond the original area, because there can always be injuries in other places that you don't see. And then you're going to want to assess their pain, and you're going to know what type of pain they have and the location of their pain. And we're going to talk more about pain when we do your vital signs and your physical assessment. So some of the nursing diagnoses that we could use for this would be impaired physical mobility related to pain and musculoskeletal impairment. We have impaired risk for constipation. related to, remember we said giving patients pain medicine and them sitting in bed not moving causes that decrease in peristalsis. So then you have activity intolerance, which could be related to fatigue and generalized weakness and exertional discomfort. You have risk for injury related to altered sensation, unsteady gait, and confusion. You have toileting, self-care deficit related to weakness and impaired mobility. Impaired transferability related to a musculoskeletal impairment. And risk for activity intolerance related to immobility. So do you see that none of these have medical diagnoses in them? These are all our nursing diagnoses and all of our nursing related tos. And just about all the things that we talked about over the last couple of slides, these are adequate nursing diagnoses that you might see your patients suffering from that suffer from immobility. So the outcome, identification and planning. For activity issues, you want to identify personal benefits of exercise. You want the patient to demonstrate correct body alignment when observed. You want the patient to demonstrate full range of joint motion and joint mobility. You want your patients to demonstrate adequate muscle mass, tone, and strength to be able to perform their ADLs in a functional manner. You want to be free from alterations in skin integrity. You want the patient to be able to show signs of adequate venous return. And then you want the patient to be free from contractures. So patients that sit for an extended period of time, a long time without moving, their bones get stuck that way. We call that contractures. And it's very hard to reverse them once it happens. So we want to implement good body mechanics. So providing patient care puts a lot of demands on the nurse's musculoskeletal system, okay? These demands are a result of the movements that are required and a use of the equipment that we have to use to provide the necessary patient care, as well as handling all of our patients. We lift, we carry, we push, we pull, and we move objects and people routinely in the course of our daily work. Performing these actions correctly is necessary because if not, we are going to have musculoskeletal strain and injury, and then we won't be able to take care of patients anymore. So ergonomics includes proper body movement in daily activities, the prevention and correction of problems associated with posture, and the enhancement of coordination and endurance. Musculoskeletal disorders plague the nursing profession. They result in a significant burden on the healthcare sector and healthcare workers. I've seen it multiple times at work. People go out, they hurt their shoulder, they hurt their back. I've seen people have multiple back surgeries, never come back to nursing. And it's really easy when you're busy taking care of patients to cut corners and just say, hey, let's pull this patient up and bed ourselves. Hey, let's just do this and not use the lift. It's very easy to do. I'm not going to lie, I've done it myself, but I usually feel it the next day when I do it. So it's not something you want to get in the habit of doing. You want to take care of your back so you can keep coming back to work and taking care of your patients. So implementing good ergonomics, this is going to include proper body mechanics in our daily activity. We already said the prevention and correction of problems associated with posture. You can see these pictures here. The girl on the right, on the left rather, she has great body mechanics. She's sitting up tall. Everything's properly aligned. The guy on the right, he's all slumped over. He's at risk for developing some type of injury. And then you have the girl on the right. This is showing you how you bend down to pick up a box instead of just bending over in half and putting all that strain on your body. And usually whoever you work for, they make you take an ergonomics class because they don't want to have you hurt yourself. So usually yearly you wind up taking an ergonomics class. So there are ergonomic programs in healthcare facilities. They prevent and decrease the jobs on the injuries. On the job site injuries, they develop lift teams to use mechanical devices. Exercise for everyone, regardless of age. Everybody should be enrolled in an exercise class. Bone health, starting with infants, is important to assure enough calcium and vitamin D are included in the diet. And then you always want to maintain a proper weight for your height, because when you're overweight, it puts a lot of strain on your bones and can cause a lot of problems. So some of the things that can cause patients to have, nurses to have injuries are when you have uncoordinated lifts. So if you're lifting your patient up in bed by pulling on their lift sheet and you move at one time, but the patient who's helping you moves later, it causes you strain. Manual lifting and transferring patients without assistive devices. If you don't have a lift in the room or a Hoyer lift and you're doing it by hand. Lifting when you're tired or after a recent back injury recovery. Maybe you hurt your back a couple weeks ago and you do it again, you're at risk for re-injuring yourself pretty quickly. Any repetitive movement such as lifting, transferring, and repositioning patients. Standing for long periods of time. Transferring patients and transferring repositioned uncooperative or confused patients. So all the things that nurses do, these are all the things on the list that put us at risk for having injury. These are part of our jobs. We stand for long periods of time. So we have to find ways for us to accomplish our job, plus be smart about it. So maybe when you're documenting, you sit down when you're documenting, you take every opportunity you can to give your feet a break and your back a break and to sit down. Transferring patients, if you have equipment present, you make sure that you use that equipment to help you. If you have someone who's being uncooperative and they don't want to reposition, you don't hurt yourself. You just don't turn them. You go and you escalate to your charge nurse. You let them know. You tell the patient that you cannot help them because you're not going to hurt yourself. And then you would document that in the chart, or you just come back in a couple hours or a couple minutes and find out if they're ready to be repositioned, or you just talk to the patient and find out why they don't want to be repositioned. You try and educate them, and if they ultimately refuse, then it is the patient's right to refuse. So tips for safe lifting. So use the major muscle groups to prevent back strain and tighten the abdominal muscles to help increase that support in the back muscles. Make sure you're distributing your weight between the large muscles of the arms and your legs to help decrease that strain on any one particular muscle group and to avoid strain on those smaller muscles. You're going to when lifting an object from the floor, you're going to flex those hips, your knees, and your back. You're going to bring that object to thigh level, bend your knees and keeping your back straight. Stand up while holding the object as close as possible to your body, bringing the load of the center of gravity to increase stability and decrease your risk of developing a back strain. So just a couple slides back, like this girl right here, see how she's keeping it close to her? She's bending her knees, she has her hips bent, flexed. That's exactly how you would want to lift something. All right, so more tips. You want to have wide bases of support and use your large muscles. Size up your load and get help if you need it. Don't ever be afraid to ask for help. Face the direction of the movement. Carry and lift those heavy objects close to you. Use the weight of the body as a force for pulling and pushing by rocking on your feet or leaning forwards and backwards. Use mechanical physical lifts as necessary. Push rather than pull equipment. If it's possible, raise patient's bed to your working height. Always, always, always do that. Lower the side rail only while at the bedside. Lower the patient's head if tolerated, and then try to not twist and turn. So here's an example of the smart way to pick up an object. You see how she's bending down, and then you see over here how she's not bending those knees. She's not getting down low. It's further away from her. She's at risk for developing an injury there. More mechanics here. It just shows you the skeletal portion versus the real person picture here. So now we're going to talk a little bit about proper positioning of our patients. This is very important, and we're going to get to practice these in labs. So There are a variety of things you can use to reposition your patient. You can use pillows, wedges, trochanter rolls, whatever your facility has and whatever they recommend. You can order specialty mattresses. There's adjustable beds. They have a trapeze bar which you can put up that will help patients be able to pull themselves up in bed. You can get different footboards, foot boats, high top shoes that cradle over top the feet. I've never seen any of that kind of stuff. I've seen us take footboards out sometimes at the end of the bed if our patients are really long and they keep sliding down, so that way they don't get them pressure points on their feet. There are some adjustable beds you can get that have particular airflow through them. They're sand beds and they keep things moving so that the patient, if they're not moving as much, doesn't get any bed sores. Some beds I've seen that turn your patients to left and right side. You can automatically program it into the bed. So these are just some, a picture of some supports that you may see in your hospital. You have, this is at the bottom is an ankle foot orthotic. This is the footboard. You can see down here at the end of the bed, see how the patient's toes and his heels are right up against that bed, that footboard. That's not okay. You would not want to allow that to happen. You would want to keep pulling your patient up in bed. You could elevate the knees under the bed a little bit. That would help the patient from sliding down. You could put a pillow under these heels to keep the heels off the bed. And if you had a bed that did so, you could remove this footboard here so that their feet were free. Here's some wedges here for you to help elevate the feet off the bed. This is just like a wrist arm brace that helps keep that arm open, that hand open. You see right here on the right versus over here, you can put like a rag in it so that way the patient doesn't get contracted. And every facility has something completely different. Some of these things I've never seen in my facility, so it's completely different. So this is the trochanter roll is what we call it. We'll learn how to do that in our clinical, but this helps to be able to keep your patient positioned comfortably. Protective positioning for the patient. So you always want to keep them in a Fowler's position. This is where the client lies supine with that bed elevated 45 to 60 degrees. This position allows for the patient's chest to expand and it allows proper ventilation. Supine or dorsal recumbent position, the client will be lying on his back with head and shoulders elevated on a pillow and his forearms on the pillows or at his side. A foot support prevents foot drop and maintains proper alignment. So I've never seen that in my facility, but we do put rolls of blankets or wedges, what we find under those prominent areas in the hospital to keep them from having that breakdown. And you could put a pillow under the foot too to keep them from touching the end of the bed. And if you wanted to see more positions and protective nursing actions, you can go to page 1160 in your Taylor book and go to table 33-6. So we talked about this a little while ago. This is the prone position. A lot of nurses are doing this position now for their patients with COVID. In the prone position, the client lies flat on his abdomen and chest with his head to one side and his back is in correct alignment. This position inhibits chest expansion, and it is only used for short-term use. And it's really cool how this works because I've been floating to the ICU to help out, and I've been taking care of patients up there that were considered IMC patients that were on like high flow nasal oxygen and vapotherm. And there's patients obviously up there that are intubated and such. And when their oxygen drops, they all go in, the nurses and the techs, and it takes a couple people to move a patient who's intubated into the prone position because you have to make sure that nothing comes apart or nothing gets dislodged or pulled out. So it takes a couple different people and you see their oxygen low, and then when you get them into that prone position and those lungs kind of like rise up and you get more air in, their O2 status increases pretty quickly. So it's pretty cool to see. So side lying is a lateral position, or we also call it the Sims position. This is when the client is on his side, halfway between the lateral and prone positions, with the weight on his anterior ilium, the humerus, and the clavicle. The lower arm is behind him, while the upper arm is in front. Both legs are in flexion, but the upper leg is flexed at a greater angle than the lower leg, as well as the knee. This is considered a comfortable sleeping position, and many people sleep this way, and I sleep this way at night too, so I can attest to the fact that it's comfortable. So transferring your patient. So you want to evaluate each situation, and you want to use a process to determine the safest method to transfer or move your client. Every patient is treated completely individually. The way one person moves is not the way another person moves. So each person is unique. So you want to be able to answer these questions. Can the client bear weight? Did they just have a surgery on their foot? Did they have a debridement? Did they have a toe removed? Did they have a break? Are they even able to bear weight? That's the first thing you want to know. Can they help you bear weight? Can they help you get to the end of the bed? Are they able to help you in any way, shape, or form assist in the move? And is the patient cooperative? Do they want to get out of bed? Are they cognitively there that they can participate in trying to get your patient to transfer? You can use gait belts and transfer belts. I see a lot of PT in my facility use those. You can do a stand assist and repositioning. You can do a lateral assist device. They have friction reducing sheets. We don't have them in our facility. You have mechanical lateral assist devices. You have transfer chairs, powered stand assist and repositioning hydraulic lifts. I've never seen them in my facility. I have seen that in long-term care though. And then powered full body lifts. So where I work, we have lifts pretty much in every single room on every floor that are mounted to the ceiling that can, they put a special pad under the patient, which has these like 5 handle straps on each side. And then those handle straps lift up and get attached to the lift. And that's how you lift the patient. Excuse me. Excuse me. And you can take them from the chair to the bed, from the bed to the chair. So when someone says we can't get the patient out of the bed, you can always get the patient out of the bed if they're stable with a chair lift or a bed lift. And we can reposition the chair that they have in the room to extend back to a lying position. And you would just move them from the bed to that chair. And then later, when they were tired of sitting in the chair, you can get them from the chair back to the bed with that lift again. And then you can keep that cloth in the room as long as it's not soiled for their entire stay, and you just keep using it as you need it. You don't keep it under the patient because it inhibits a good flow of air, and it can contribute to skin breakdown. But you can use it to reposition them. This is just an example here of a mechanical lateral transfer device. You see these mainly in long-term care facilities. I've never seen them at my hospital. The thing that she's sitting in is pretty similar to what we use to get a patient into a chair. It's just that our lift is mounted to the ceiling. So a good thing when you're doing these, especially with your older patients, they are so afraid of falling. And they always think that once it starts moving that they're going to fall. So you want to offer a lot of reassurance, make sure that you're standing next to them and keep reminding them that you're taking care of them, that they're safe, and that they're not going to fall because they get really scared. So this is moving the patient up in bed utilizing a 2-person assisted method. I've seen it done like this, and then I've also seen it done where there's a lift sheet underneath the patient, and then it's right underneath their bottom, and each person grabs the side of the sheet and pulls them up in bed. This is kind of like a stand assist. So this is transferring from a lateral position. So the patient was laying down, then they went to a sitting up position, and now we're going to transfer them. It looks like there's a bedside commode there, so they're going to turn and pivot. Then they're going to sit down on that bedside commode. Or maybe they're getting into a chair. I can't see from the picture what's behind them. But you always want to make sure that whatever you're moving them from is locked, like the bed. And if you're moving them to a chair, make sure that the chair is locked. And you're going to make sure you educate that patient, give them clear and brief instructions to make it a positive experience. And you might have to keep repeating them instructions over and over again, depending on the cognitive ability of your patient. Sometimes they need frequent reminding. All right. So this is lowering a patient to the floor. So I've seen with myself, I've seen it with other nurses, and I've seen it with PT. When the patient is walking, they start off doing very well, and then they just get tired very quickly, or something happens and they get too weak to walk. So I've seen them with physical therapy. When they walk with people, they always have two people with them, and they walk with the chair behind the patient. The recliner walks behind them in case they have to sit down. But sometimes they don't have that chair, and it's not ideal, and the patient gets very weak, and you can't hold them up and risk hurting yourself. So you have to be able to lower that patient to the floor, keep them from falling and hurting themselves while protecting yourself. So you can support the client's body against yours and then gently slide the client onto the floor. So that's like what they call, in some facilities call that an assisted fall. So then you have walkers, which are lightweight metal frames. They're usually made of aluminum. They have 4 legs. They help the patient to walk and ambulate. They improve their balance by increasing the patient's base of support. It enhances their lateral stability and supporting the patient's weight. A cane widens a patient's base support, and it provides that improved balance and improves the client's quality of life. So if a patient can still walk around, but they need assistance, this is something you want to advocate for. You want them to be as independent as they can be. Some patients might not want to be using a cane. Maybe they came into the hospital and they didn't have to use a cane or a walker beforehand. So there's going to be a lot of education going along with that. Listen to your patients. Remember, we talked about that self-esteem. That's all part of it. All right, so cane instructions. If you are teaching a patient to use a cane, you're going to maintain 2 points of support on the ground at all times. You want to make sure that your cane is positioned on the stronger side of the body. So if your patient is using a cane to ambulate who just had a left hip fracture, you're going to put that cane on the right side of the body. You're going to support the body weight on both legs, and then you're going to move that cane in the right arm on the right side of the body forward approximately 6 to 10 inches. And then once you move that cane forward, you move the weaker leg toward the cane. So the cane always goes on the stronger side of the body, but the affected extremity moves first. And then you advance the stronger leg past the cane. If a patient gets crutches, you do not alter the crutches after they've been fitted by physical therapy, or usually it's physical therapy or OT, they fit the patient for them. You want to follow the prescribed crutch gait, whatever instructions came from physical therapy or occupational therapy. You want to support the body weight on the hand grips with the patient's elbows flexed at about 30 degrees. You want to position the crutches on the unaffected side when sitting or raising from the chair. So whenever you're sitting or whenever you're coming out of a chair, those crutches want to be on the unaffected side. And then if you want more information on some more teaching tips, you can go to page 1171 of your Taylor, and it's going to be section 33-1. So here are just some braces. This guy over here has a foot boot. He may have had some type of surgery. Maybe he had toes amputated, or he had an ankle fracture, something like that. These are some forearm crutches that I've seen patients have. The guy on the left, he has just regular auxiliary crutches that go underneath the arms, and they have your hands that rest on those little pads midway to his waist. You see how his elbows are flexed, like we talked about, that 30 degrees. You want to avoid, usually these things are only used for a small amount of time, just to help until that affected extremity is strengthened again, or whatever body part is has an injury. And this over here is just a right knee brace. So we talked about nutrition being very important for our patients' healing. So some interventions that we can provide to our patients. So we can provide a high protein, high caloric diet with vitamin B and C supplements. Our patients need about 2,000 to 3,000 mLs of fluids per day. We want our patients' diets to be rich in fluids, fruits, vegetables, and fiber. We want them to eat 5 to 6 small meals a day. That can be hard in the hospital because they usually only get 3 meals a day, but it would be a great goal for when they're home. You can allow family to bring in their favorite foods, especially if they don't like the hospital food. If a family wants to bring in something that you know that the loved one is going to eat, that their loved one's going to eat, let them bring it in. The important thing is that your patient gets a good diet and they start eating. And then you want to provide a social, engaging environment to eat. So maybe your patient needs help setting up their tray. Maybe it's hard for them to do it. Go in and say, hey, Mr. Jones, I have your meal. Can I help you? Can I help set you up? What do you like to drink? Can I bring you any ice? Really work with the patient and try and make it as pleasurable as you can. So some interventions, again, just to recap, to help that perfusion in the body. We want to teach those leg, foot, and ankle exercises, then foot pumps and those extensions of your ankles and your feet and flexion exercises. You want to make sure that they're getting fluids. You want to provide those frequent position changes to keep all that blood flowing. You want to use those sequential comprehension device stockings. You're going to call them SCDs. And then those anti-embolism stockings. So sequential compression device stockings, you never call them that in the hospital. You're going to call them SCDs. Those SCDs, they put them on before you have surgery, when you're going into the OR. Sometimes they're on when you wake up in the OR, and then our med surg floors, we give them to prevent blood clots. So they go around the lower part of the legs between the ankle and the knee, and they Velcro on, and then they connect to these 2 little tubes, and then they're connected to a motor. You turn that on, and it pumps air and squeezes that device that you placed on the legs, which helps squeeze the leg and push that blood return back to the heart. So it increases that perfusion, and it decreases the risk of getting a blood clot. And then we have those TEDs, which we showed a couple slides back, them anti-embolism stockings. You can put those on your patients. Sometimes patients are ordered both TEDs and SCDs. And then what does evidence-based practice say about anti-embolism stockings? So you guys can look that up, and someone can have the answer for that when we come for our live lecture. So evaluating, so we talked about the problems, we talked about what we were going to do to implement, okay, part of that ADPI. Now we're evaluating. So we're going to evaluate the patient for signs and symptoms of their changes in their mental status. Has the patient improved? Have they deteriorated, and what changes must I make now to improve that plan of care? What's the patient's perception of their mobility status? What do they think they could do? I know a lot of patients that come in. I took care of a man just a couple of weeks ago who had 4 falls at home. 4, okay, just in that one day. He had many previously to that. After I got him set in bed and I did my assessment and I was going to leave the room, I put in his bed alarm, and he asked me what that sound was. And I said, well, that's your bed alarm, because you've had some falls in the past and you are on some medications that put you at a higher risk of fall. And this isn't your normal environment. So I want to make sure that if you forget where you are and you go to stand up, that it lets me know so that I can come and help you before you fall. Well, I'm not going to fall. I didn't really have 4 falls. She's just making it up, is what he said about his wife. So what is your patient's perception of their mobility status? And has the patient experienced complications from immobility? So these are all the things you want to think about. All right, guys, that was it for mobility part 1. Your next lecture is going to be communication.